Good morning, everybody, or good afternoon. It's my pleasure to welcome everyone to day 3 of the workshop, and I'm very happy to be co-chairing this session with Dr. Andrea Calcagno, who's the Professor of Infectious Diseases at the University of Torino. My name is Alice Tsang. I'm a pharmacist at Toronto General Hospital, and I'm with the Faculty of Pharmacy, University of Toronto. So before we get started, just a quick reminder that you can post your questions to the presenters. We have 2 presenters for this first part, for session 5, and there will be a live faculty discussion afterwards. So at any time, you can type your questions into the live Q&A session. I would also like to take this moment to acknowledge all our corporate sponsors for supporting this workshop. And for this first session for today, I'm honored to introduce Dr. Vikram Arya, who is a clinical pharmacology team leader in the Division of Infectious Disease Pharmacology, Office of Clinical Pharmacology, Center for Drug Evaluation and Research at the FDA. He is also currently the president of the American College of Clinical Pharmacology. And today he will be giving a presentation entitled Perspectives on the Use of Endogenous Biomarkers to Assess Transporter-Mediated Drug-Drug Interactions.
Good morning and good afternoon. It is truly an honor to present my perspectives on the use of endogenous biomarkers to assess transporter-mediated drug-drug interactions. I would like to start by thanking the organizers for including a discussion around this rapidly emerging topic in this year's workshop and for providing me with an opportunity to present. Here is my disclaimer. The contents of this presentation are my own and do not necessarily reflect the views or policies of the U.S. Food and Drug Administration. Also, I have no conflicts of interest to disclose. Before I start my presentation, I would really like to thank Drs. Kelly Reynolds and Xining Yang for their extremely helpful feedback on the information that I'm going to cover today. Their input really helped me put together several core concepts and streamline the presentation. Here is the roadmap for today's discussion. I will provide an overview on why transporter-mediated drug-drug interactions or DDIs are assessed in drug development. What is the typical approach of assessing transporter-based DDIs? Introduce the conceptual framework around the use of endogenous biomarkers to assess transporter-based DDIs due to inhibition of transporters, and with the help of some examples, demonstrate how endogenous biomarkers can serve as an important tool and complement other available approaches to assess transporter-based DDIs. I will also highlight some current challenges and knowledge gaps related to the use of endogenous biomarkers to assess transporter-based DDIs, and then wrap up the talk with some concluding remarks. So let us start with the basic question on why transporter-based DDIs are assessed. As we all know, transporters are membrane-bound proteins which regulate the access of molecules across the cells and control the overall distribution of drugs to their intracellular site of action. Either alone or in conjunction with enzymes, transporters play an important role in modulating the absorption, distribution, metabolism, and elimination, and thereby the PK and/or PD characteristics. Hence, evaluating transporter-mediated DDIs during development and post-approval is an important part of benefit-risk assessment. In fact, various regulatory agencies also recommend the assessment of transporter-based DDIs during and post-approval. In 2018, the International Transporter Consortium, or the ITC, published a white paper to summarize their recommendations on transporters that are important to consider as part of drug development. In addition to the newly emerging transporters important in mediating DDIs, for example, the hepatic OCT1 and the intestinal and hepatic OATP2B1, the consortium members also highlighted the role of transporters in mediating drug-induced vitamin deficiencies, for example, the thymine transporter THTR2, and the involvement of OAT2 in the active renal secretion of creatinine. The figure on this slide shows the uptake and efflux transporters in various tissues. Just a few notes about the color coding for the various transporters described in the figure. The red circles represent transporters previously recommended by the ITC and the ones which are also recommended for evaluation by the various regulatory agencies. The yellow circles, for example, the MRPs and the BSEP, are transporters recommended for retrospective mechanistic evaluation of clinical observations. The green circles, hepatic OCT1, is recommended by the ITC to evaluate whether a drug is a substrate and/or inhibitor of OCT1. The yellow square, the intestinal and the hepatic OATP2B1, is also recommended by the ITC for retrospective evaluation in case of DDIs that cannot be explained by common mechanisms. The blue circles denote transporters for which sufficient evidence is currently lacking for specific recommendations by the ITC. So now let's discuss the typical stepwise approach of assessing whether a drug is an inhibitor of a transporter. So in terms of assessing transporter-based DDIs, usually a combination of in vitro approaches in silico, for example, mechanistic, static, or PBPK modeling, and in vivo, if the need is determined based on in vitro and in silico assessments, is followed. As the first step, we would typically compare the inhibitor concentration, be it dose divided by 250 ml for PGP or BCRP transporters, the hepatic inlet concentration for OATPs, or the unbound Cmax used for assessing renal transporter-based DDIs with the IC50 and compare this ratio with the cutoff. So, for example, 10 for PGP or BCRP or 0.1 for renal transporters. If this ratio happens to be below the cutoff, then no additional follow-up is needed. But if the ratio is above the cutoff value, either advanced static or dynamic, for example, PBPK modeling or a DDI trial is recommended. However, two questions often come up. One, if the ratio is below the cutoff value, does that mean significant DDIs will never be observed in vivo? And second, if the ratio is above the cutoff value, does that mean significant DDIs will always be observed in vivo? So here, the operating words be never and always. Well, the answer to both these questions is no. In the first case, we generally end up with false negatives. So this would be a case where in vitro data does not suggest the potential for in vivo DDIs, but in vivo DDIs are observed. And in the second case, we generally end up with false positives. So this would be a case where in vitro data suggests the potential for in vivo DDIs, but in vivo DDIs were not observed. In the next slide, I will present some data to further illustrate this concept. So in 2016, we conducted a retrospective analysis in which we compared the various in vitro prediction methods for assessing the potential of a new molecular entity to inhibit OATP1B1 transporters. Very briefly, what we did was we calculated the cutoff value using 6 different prediction methods as shown in the table and compared the predictions regarding potential for DDIs with the observed DDIs. So our database included 11 substrates, 61 inhibitors, and DDI data from 107 DDI studies. So it was a very robust database. As you can see in the table, no matter which prediction method we used, we always ended up with some false positive and some false negative predictions. So a logical follow-up question is that what could be some reasons for false positive and false negative predictions? So there could be multiple reasons, such as inter-system and inter-laboratory variability in determination of IC50 values, which would then affect the outcome of the various prediction methods. The second is generally only the parent form of the drug is considered, and the inhibitory properties of the metabolites are not taken into consideration. So if the metabolite also happens to inhibit OATP1B1, in this case, calculations using only the parent may not provide the complete picture. And the third, multiple transporters may affect the ADME properties of the substrate, whereas the prediction method considers only one transporter. So if the drug happens to be an inhibitor of multiple transporters, one can expect that we will end up with some false negative predictions. So with this background, let us discuss the conceptual framework for the use of endogenous biomarkers to assess transporter-based DDIs. So what are these endogenous biomarkers? In a nutshell, these are endogenous compounds which also happen to be substrates of the various uptake and efflux transporters. So the basic idea is that if we can assess changes in the disposition of these endogenous compounds after administration of an inhibitor, we can also integrate this information with the available in vitro information to better predict the potential for an in vivo DDI. The figure on this slide shows the potential biomarkers currently being explored to assess DDIs via modulation of various transporters. For example, Coproporphyrins 1 and 3 are being actively investigated for assessing the OATP1B inhibitory potential of drugs. As far as renal transporters go, alterations in creatinine levels due to inhibition of renal transporters by drugs such as dolutegravir and cobicistat is well known. Regarding other endogenous biomarkers, a very recent publication in Clinical Pharmacology and Therapeutics also suggested that in addition to N-methylnicotinamide and methyladenosine may also show some promise as an endogenous biomarker. So what could be some potential benefits of using endogenous biomarkers to assess transporter inhibition? The first potential advantage is that the effect of transporter inhibition can be assessed over a wide range of inhibitor exposures because we are assessing the PK of the inhibitor drug over a wide range of exposures early in development, as opposed to a dedicated DDI trial where only one or sometimes two doses are evaluated. And if there are early signals of transporter inhibition as assessed by changes in the levels of endogenous biomarkers, this information can be very helpful to prioritize subsequent in vivo DDI trials. In addition, information on alteration in biomarker levels can also be important to inform concomitant medication use, especially in cases where results from in vivo DDI trials are not available. Lastly, changes in the levels of endogenous biomarkers can help with mechanistic understanding of the observed DDIs, and I will further discuss this point with the help of an example later in the presentation. So the concept of using endogenous biomarkers to assess transporter inhibition is definitely an important emerging and exciting area of research. In the interest of time and considering that the majority of the work in this area so far has focused on evaluating endogenous biomarkers of OATP1B transporters inhibition, in the remaining part of the presentation, I will focus on endogenous biomarkers that are being used to assess inhibition of OATP1B transporters. So the most widely used endogenous biomarkers for assessing OATP1B inhibition are coproporphyrins 1 and 3. Both CP1 and CP3 are organic anions and porphyrin metabolites of heme biosynthesis. Being organic anions, they are taken up into the hepatocyte by OATP1B1 and OATP1B3, and then there is emerging data to suggest that CP3 is also taken up by OATP2B1. They are eliminated either by urinary elimination or by biliary efflux mediated via the MRP2 and the MRP3 transporters. For the purposes of our discussion, it is important to note that inhibition of OATP1B1 transporters can increase the levels of both CP1 and CP3, something that I will discuss in more detail in the next slide. We all know that rifampin after a single dose is an inhibitor of OATP1B transporters, and rosuvastatin is the substrate of OATP1B and BCRP transporters. So if a single dose of rifampin is co-administered with rosuvastatin, one would expect increase in the concentration of rosuvastatin due to inhibition of OATP1B transporters by rifampin. To demonstrate this, Lai et al. Evaluated the effect of single-dose rifampin on not only rosuvastatin, but also on CP1 and CP3. So the graph in the upper panel shows the concentration of rosuvastatin as a function of time. The solid circles show rosuvastatin concentrations when given with rifampin, and the open circles show rosuvastatin concentrations when rosuvastatin is co-administered with rifampin. As expected, rifampin increased the Cmax of rosuvastatin by approximately 13-fold and AUC by 5-fold. The lower panel shows the concentration of CP1 on the left and CP3 on the right as a function of time. Rosuvastatin is not known to inhibit OATP1B transporters, hence no change in the CP1 and CP3 concentrations were noted. However, after co-administration with rifampin and rosuvastatin, the Cmax and AUC of CP1 increased by 5.7-fold and 4-fold respectively, and the Cmax and AUC of CP3 increased by 5.4-fold and 3.3-fold respectively. Overall, simultaneous assessment of changes in the pharmacokinetics of an exogenously administered known substrate of OATP1B, rosuvastatin in this case, and endogenous biomarkers CP1 and CP3 shed light on the potential role of these endogenous biomarkers in assessing DDIs mediated by inhibition of OATP1B transporters. So the next question to consider is whether the effect of rifampin on these endogenous biomarkers is dose-dependent. In other words, do we expect a greater magnitude of increase in CP1 concentrations if a higher dose of rifampin is used? To address this question, Takihara et al. Explored two different doses of rifampin, 300 milligrams and 600 milligrams. As shown in the graph on the left, the effect of rifampin on CP1 is dose-dependent. In addition, as shown on the graph on the right, increase in CP1 exposures after 600 milligram rifampin is statistically different from the increase in CP1 exposures after 300 milligrams rifampin. Now that we know that the levels of CP1 and CP3 can be affected by OATP1B inhibitors such as rifampin, let us explore how this information may be used to elucidate the mechanism of complex DDIs. So Jones et al. Assessed the effect of fenebrutinib, an inhibitor of CYP3A, BCRP, and OATP1B, on pharmacokinetics of midazolam, a substrate of CYP3A, simvastatin, a substrate of CYP3A and OATP1B, and rosuvastatin, a substrate of BCRP and OATP1B. The authors also measured the levels of CP1 and CP3. So as you can see, the AUC of both midazolam on the top panel and simvastatin in the bottom panel increased approximately twofold, suggesting fenebrutinib is an inhibitor of CYP3A. Increase in concentration of simvastatin may also suggest that fenebrutinib is an inhibitor of OATP1B transporters, considering that simvastatin is a substrate of CYP3A and OATP1B. However, no firm conclusions can be drawn just by looking at this data. With fenebrutinib, the Cmax and AUC of rosuvastatin, a substrate of OATP1B and BCRP, increased by 5-fold and 2.6-fold respectively. But with this data, again, it is challenging to draw firm conclusions regarding the effect of fenebrutinib on OATP1B versus BCRP. This is very similar to the previous slide where it was challenging to draw firm conclusions regarding the effect of fenebrutinib on 3A versus OATP1B based on changes in simvastatin exposures. In this type of a situation, having information on the levels of CP1 and CP3 was very helpful. The graph in the lower panel suggests a lack of effect of fenebrutinib on CP1 and CP3, indicating that fenebrutinib is not an inhibitor of OATP1B transporters. Hence, the effect of fenebrutinib on simvastatin appears to be primarily due to CYP3 inhibition, and the effect of fenebrutinib on rosuvastatin is primarily driven by inhibition of BCRP transporters. And this type of assessment has important implications. For example, one may draw a conclusion that OATP1B substrates can be co-administered with fenebrutinib without any dose adjustments. And this is important to know considering there are many established OATP1B substrates. Overall, having information on CP1 and CP3 levels was helpful in elucidating this complex DDI. So in the last part of the presentation, I will outline a few challenges and knowledge gaps that still need to be further addressed before CP1 and CP3 can be fully integrated into the overall DDI assessment paradigm. The first challenge is that there is very limited clinical data to verify the performance of endogenous biomarkers with inhibitors of varying potency. The majority of the data currently available is with rifampin, which is a potent inhibitor of OATP1B transporters, but there are relatively fewer published reports on the effect of less potent OATP inhibitors. Hence, currently, it is challenging to comment on how sensitive CP1 and CP3 are to OATP inhibitors other than rifampin. The second challenge is that there is very limited data to directly compare the magnitude of changes in the level of an exogenously administered transporter substrate to the magnitude of changes in endogenous biomarkers after an inhibitor is given. In the absence of such data, extrapolating the effect of an inhibitor solely based on its effect on an endogenous biomarker becomes challenging. So in other words, if an inhibitor of a certain transporter increases the level of an endogenous biomarker by 4-fold, for example, does that mean it will also increase the levels of an exogenously administered substrate of the same transporter by 4-fold? And the third and the fourth challenge pertain to how variable are the baseline levels of the endogenous biomarkers and what potential factor or factors can contribute to the variability. The more variable the baseline levels are, the harder it gets to obtain a good estimate of changes in endogenous biomarker levels due to an inhibitor. The last challenge is about the analytical sensitivity, considering that the systemic levels of these biomarkers are generally in the low nanomolar range. So unless we can accurately assess the endogenous biomarker levels using validated assays, drawing firm conclusions will definitely pose some challenges. So just some concluding remarks to wrap up my talk. Data is definitely emerging regarding the use of endogenous biomarkers to assess transported DDIs. Preliminary data suggests that CP1 and CP3 may play an important role in the assessment of DDIs mediated by OATP1B transporters, but there is ongoing research to evaluate biomarkers for other transporters. There are several knowledge gaps that need to be addressed to comprehensively understand the role of endogenous biomarkers in the overall assessment of DDIs. With that, thank you very much for your time and attention, and I look forward to addressing questions you may have. Thank you.
Thank you very much, Dr. Arya, for an excellent talk. Look forward to your contributions in the faculty discussion later on in this session. Just a reminder for audience members, at any time, please feel free to type in questions for our speakers. And if you have a specific question, please also indicate who it's for. With that, I would like to move on to the next presentation by Dr. Dario Cataneo, who is with the Unit of Clinical Pharmacology at Luigi Sacco University Hospital in Milano, and he is also the president-elect of the International Association of Therapeutic Drug Monitoring and Clinical Toxicology. And he will be presenting on the role of herbal and complementary and alternative medications in drug-drug interactions.
Good morning, everyone. These are my disclosure. So what we're talking about today. So we are talking about herbs, Ayurveda, Chinese medicine, and these terms are used with the more general concept of complementary and alternative medicine, which are a group of diverse medical and healthcare system, practice, and products that are not generally considered part of conventional medicine. So just to give you some numbers, this is a study. This table summarizes the study available dealing with the use of complementary and alternative medicine in HIV-infected patients. As you can see from the table, there is quite heterogeneity, but the frequency, the percentage of CAM use ranges from 16% up to 95%. So this means that a very high number of HIV-infected patients use complementary and alternative medicine in their life. So which are the reasons for using CAM by HIV-infected patients? Number one is for general health and well-being. Two, improve immune function, increase energy, reduce anxiety. But there are also, they use CAMs also for specific pathological conditions such as lower cholesterol, treat diarrhea, etc. So, which are the types of complementary alternative medicine that are used by HIV-infected patients? As you can see from the figure, medicinal herbs is used by more than 90% of HIV-infected patients. So that's why today we are talking about herbs and the potential drug-drug interaction. But the most important information that we can retrieve from this study is that less than 1% of HIV-infected patients that use CAMs inform their healthcare providers of CAM usage. And this is a big issue because if you want to understand potential drug-drug interactions, you need to know that your patient is assuming herbal products. So this is really an important topic. So other information from these surveys in the upper side, the basis for choosing the right CAM therapy, as you can see here, nearly 50% of the interview HIV-infected patients don't know why they choose their CAM therapy. And this is really another thing that this is important to consider. And if you go in the downside, the source of awareness about the type of CAM therapy used, in less than 10%, this source was represented by healthcare or hospital personnel. So in the large majority, mass media, other patients, CAM practitioner, and etc. So the second point is what are the risks, the potential risk for the patients, for the HIV-infected patients of using complementary and alternative medicine? As you can see from this study published in 2007, the authors reported a highly significant associations between the use of complementary alternative medicine and the risk of non-adherence to antiretroviral therapy. So this is really an important point. And this was confirmed by another study published some years later. Again, if you look at the table and the last line, the adherence to antiretroviral therapy was nearly 90% in CAM non-users and 80% in CAM users. Again, they reported an association between use of complementary and alternative medicine and the risk of pure adherence to antiretroviral regimen. So other risks may be related to specific toxicity of herbal remedies, as in this case. In this study, the author reported an association between liver fibrosis and the use of traditional herbal medicine from Uganda. The use of these herbs was the strongest predictor of liver fibrosis. And the third risk is represented by drug-drug interaction, and this is the topic of my talk of today. So if you use herbal remedies, you may pay attention because these products may induce some important interaction with the antiretroviral and non-antiretroviral medications. So if you think about herbs and drug interaction, all of you knows that the top layer is Hypericum perfuratum. There are a lot of literature have been published in the past years dealing with this topic. These studies shows that there is an association between the content of hyperforin, which is the main ingredient of Hypericum perfuratum, and the induction of cytochromial enzyme. And especially this induction relates to cytochrome 2C19, 3A, 2A1, but not only cytochromial enzyme, but also transfer protein, as in the case of P-glycoprotein. Which are the effects? This has been studied nearly 20 years ago, but these figures clearly shown that if your HIV-infected patient is given Hypericum, the risk to reduce the exposure of antiretroviral medication range from 30 to 80%. So it's really an highly significantly effect. Not only Hypericum, of course, there are other drug interaction involving antiretroviral medication and herbal remedies. This is the case of garlic supplements. So this study shows that 20 days of treatment with garlic supplement resulted in a 35 to 50% reduction in the Saquinavir area under the curve. So again, a highly significantly impact on antiretroviral exposure. And these data have been summarized in this very well done review published in 2008. The author shown here two types of warning. Number one is the warning that results in advice to stop doing so, and they relate to echinacea, garlic, kava, Hypericum, and a warning in which it is important to monitor for potential side effects: aloe vera, cat's claw, ginkgo, ginseng, licorice, etc., etc. So more than 10 years ago, we have very good results with the potential drug-drug interaction involving antiretroviral medication and herbal remedies. This is another review published 10 years later in 2017. Again, drug interaction in HIV treatment dealing with complementary and alternative medicine. And as you can see here, there are also new drug-drug interaction that involve also more new antiretroviral medications such as dolutegravir, elvitegravir, and maraviroc, and Humulus lupulus, pipermesticum, glycyrrhiza, shark cartilage, yoimbe, that are herbal-based remedies that are used for different heterogenic conditions, sexual enhancer, sedative, antidepressant, anti-inflammatory, aphrodisiac, etc. But the key message is that with time, new evidence of potential interaction between herbal remedies and antiretroviral medications can be identified. And these are two more recently published case reports dealing with the new interactions that relates to the use of Equisetum arvense, also known as horse tails. These herbal remedies is mainly used as diuretic or for the treatment of digestive disorder, kidney bladder storm, hemostatic, astringent, so potential implications. There are a few data for its potential to induce drug-drug interaction, and for this reason, according to FDA definition, horsetail has been listed as an herb of undefined safety by the FDA. So the two case reports are quite similar. One is a male and one is a female. Both patients had a long story of antiretroviral treatment with optimal virologic control. And what they experience is that a few weeks after starting supplement containing horsetail, both patients experience an increase in the viral load. So the suggestion was to stop immediately horsetail, and viral load performed 1 month later stopping Equisetum resulted in a viral load resuppression. So this is an indirect evidence that the key player of this drug-drug interaction was Equisetum. The potential mechanism, hypothesis 1, is that Equisetum may induce cytochrome 2b6 because both patients were treated with efavirenz. Hypothesis 2 is that Equisetum may increase the renal elimination of 3TC, FTC, and tenofovir. Third hypothesis is that in some way Equisetum may impair the absorption of antiretroviral medications. And the fourth one is that this drug-drug interaction may be related to adulterants. The key limitation of this study is that the authors did not present data on therapeutic drug monitoring of antiretroviral medication. But up to now, we have dealt with the potential interaction between herbal remedies and antiretroviral medication, but infectious disease physicians should pay attention also to non-antiretroviral medication, because as this study shown, the large majority of drugs that are given to HIV-infected patients are non-antiretroviral medication. So it is important to look also of this drug-drug interaction. And there are a lot of data showing that herbal remedies may interact with non-antiretroviral medication. This is a review published in Pharmacological Research in 2017. Again, it's ginkgo biloba, ginseng, hypericum, aloe, salvia. And this is another review published in 2016, and the list is even higher. So we have Acta racemosa, Catarancus, Vaccinium, Harpophytum, Echinacea, etc., etc. And the key mechanism for the observed interaction between herbal remedies and non-antiretroviral medication is via an induction or an inhibition of cytochromial enzyme. So the list of the potential herbal drug interaction is very high. But what about potential herb drug interaction involving not cytochromial enzyme, but phase 2 metabolism? This is a study published last year in Pharmacological Research, very well done study, in which the authors have reviewed the available literature and have shown that there are some herbal remedies such as glycyrrhiza, Kaempferia, Hauranti, Morus alba, Scutellaria, that are strong inhibitors of UGT, uridine diphosphate glucorosyl transferase, which is a phase 2 enzyme. So according to IC50 values, these are strong. This can be considered as a strong inhibitors of this phase 2 enzyme. And this inhibitory effect may be addictive or synergic. So it means that if you have an HIV-infected patient that is on atazanavir-based antiretroviral medication, and if you add, for instance, glycyrrhizia, which is another inhibitor of UGT, the inhibitory effect may be addictive and the clinical implication may be highly relevant. So pay attention when you want to check an interaction between herbal remedies and antiretroviral or non-antiretroviral medication, that this interaction do not deal exclusively with cytochromial enzyme. And phase 2 enzymes inhibitions is important also because the most important class of antiretroviral medication that we have in our hands now are integrase inhibitor. As you can see from this figure, elvitegravir, dolutegravir, and bictegravir are mainly metabolized by UGT. So this means that the potential drug-drug interaction between this class of drugs and herbal remedies that have in some way some effect on UGT, it is must be taken into account, especially if you have a patient with a genetic background for which the baseline activity of UGT may be altered. There are, of course, some important tools that we can use to check for potential herbal drug interaction. These are 3, but probably if you surf in internet, you can find many others. These are the drug interaction checker from WebMD, specifically devoted to UTC and herbal supplements. This is the Stokely herbal medicine interaction and the MediHerb. But the key message is that you have online several tools to check for herbal drug interaction. Please use this tool because they are really important for the optimal management of your patients. And now I would like to spend the last 5 minutes of my presentations dealing with sharing with you my personal experience with the herbal drug interaction in HIV-infected patients from our outpatients service that together with my colleague Cristina Gervasoni, we have created 3 years ago. Actually, we have in our database more than 1,000 HIV-infected patients on polypharmacy, and some of them are also given herbal remedies. So what we have observed in these years, this is a study that we have published a couple of years ago. The first 2 cases, this with the Orlistat, so it's not an herbal remedies, but the third one, which is a patient that experienced loss of control of HIV viremia while he was treated with the weight loss drugs. In this case, we have a patient that suddenly experienced a dramatic reduction in the atazanavir trough concentration to subtherapeutic levels, and asking him, we discovered that she was given Sinetrol. What is Sinetrol? Is a supplement that contains naringin, which is, so it's an herbal derived supplement. Naringin is extracted from citrus fruits, and it has been shown, there are a lot of literature showing that naringin can inhibit the activity of carrier protein, including P-glycoprotein, and this may result in impaired drug absorption, as the case that we documented with atazanavir. The 4th case, it's a male that again experienced loss of control of HIV viremia, and we have no data on TDM, but the fact is that we discovered that he started a few weeks before experience the HIV viral blip, that he started to be given Unabasic and Lipidum. So we focused on Lipidum. Lipidum is again an herbal remedies, contain phytosterols, mainly from psyllium extracted from Plantago ovata. And there are in literature some publications showing that psyllium may inhibit again the absorption of some drugs, as in the case that we observed. Another experience, personal experience, 2 years ago, we have a patient with a long good story of optimal virological control. Suddenly, the concentration of elvitegravir dropped from 800 nanogram per ml to 50 nanogram per ml, so a dramatic reduction. And we discovered that he started a few weeks before using CAT4-HIM, which is a thermogenic complex that he used to increase his muscle definition. And this supplement contains gugulsterons. Gugulsteron is a phytosteroid, so it's an herbal remedy, which is found in the resin of the guggle plant, especially in Commiphora mucul. And if you look in literature, there are evidence showing that gugulsteron can activate the pregnein X receptor, and this may result in the induction of cytochrome 3A, 4, and 5, which are the two enzymes that are involved in the metabolism of elvitegravir. So that's why we see this dramatic reduction in the elvitegravir concentration. Last case, it's a 42-year-old man, long-term history of HIV treatment, optimal virologic control. He was on treatment with dolutegravir, abacavir, and lamivudine. And we periodically measured the dolutegravir trough concentration, and the concentration were always largely above the minimum effective concentrations. So last year, the general practitioner prescribed him a dietary supplement containing Hypericum perforatum because of the treatment of persistent severe depression. So he was admitted to our outpatient clinics, and the first question that we have to solve was, should the dose of dolutegravir be changed now that the patient started the supplementation with Hypericum? We look at the drug summary product. As you can see from this figure, there are no studies specifically published dealing with this drug interaction, but the suggestion from the drug monograph is to double the dose of dolutegravir. So ideally, we should have increased the dose from 50 milligram once daily to 50 milligram twice daily. However, taking in consideration the very good exposure to dolutegravir trough concentration, we decided not to double the dose and to see what happens. This was what we observed. If you compare the dolutegravir trough concentration before versus concomitant Hypericum co-administration, you see that there are no significantly variation in the dolutegravir trough concentration. So probably we took the right decision when we decided not to double the dose. The second question was why the dolutegravir concentration are not reduced by Hypericum. We have to go back to the information that we have, and dolutegravir is mainly metabolized by UGT, not by cytochromial enzyme. And there are a few data, but consistently these studies have shown that Hypericum does not significantly induce UGT. So this drug interaction was not expected. We don't know why in the drug monograph it was suggested to double the dose, because there is no strong rationale. The third question was, what would have happened if we doubled the dose as suggested by the drug monograph? So if you assume a linear drug pharmacokinetics, the trough concentration of dolutegravir could have increased from 1,400 to 2,700, 800, and this concentration have been recently associated with an increased risk of for the patient to experience neurological complication. So from this observation, there are, of course, important limitations. Number one is that we have no information on the hypericin content. But the fact is that if we have doubled the dose of dolutegravir as the drug monograph has suggested, we might have increased the risk of neurological complication in our patient. And if you want to get more information from this publication, this is the reference. Probably these examples show how it's a very important tool to monitor for potential drug interactions involving herbal remedies is by therapeutic drug monitoring. So this is the end of my conclusion. I would like just to end with these slides. As the incoming president of the International Society of Therapeutic Drug Monitoring and Clinical Toxicology, I warmly invite you to attend our meeting that hopefully will be held in Rome in 2021 from September 19 to September 22. Thank you very much for your attention.
So, good morning, good afternoon, good evening. It's also a pleasure to share with you and to discuss with you this wonderful presentation And so I will start with one of the questions for Dr. Arya. So the first one, if you could talk on the relative merits of a biomarker approach in comparison to a more typical cocktail metabolic probe study. I think it's also related to another question suggesting how specific are endogenous substrates for transporters.
Sure. So happy to be here and address the questions. So I think the first question is very interesting in terms of comparing and contrasting the endogenous biomarker approach versus the typical probe substrate cocktail approach that is used. It's interesting because both approaches sort of address the same question on whether a drug is an inhibitor or certain transporters or not. I think the difference lies on where we employ the approaches. So one big difference is that for an endogenous biomarker approach, you can assess the effect of an entire dose range on the endogenous biomarker, and a practice which is typically not conducted when you're doing a drug interaction trial with exogenously administered probes of different transporters. The way I look at it is that these approaches are complementary. So for example, initially in development, if you have a validated biomarker that you can assess, you can get a good sense of whether my drug is an inhibitor of, let's say, OTP1B1 and let's say some renal transporters. And then I can do later a probe cocktail study with only the substrates of those transporters. So in a way, both these approaches are kind of complementary. It depends on where these are employed in the whole spectrum of drug development. Now, in terms of how specific these endogenous biomarkers are for the certain transporters, from the literature that I have reviewed and looked at, it looks like CP1 is pretty specific for OATP1B1. And this is coming not only from the clinical trial data, some of which I presented, but also from the GWAS studies, which have been recently published. Now, beyond their CP1 for OATP1B1, the jury is still out on a lot of other biomarkers for transporters. But the majority of the published literature is primarily for CP1 and a little bit on CP3, but beyond CP1 and CP3, we don't really have a lot of information yet. So one is we need to identify those biomarkers, validate those biomarkers, assess them across the range of different inhibitors, and then we can start to have a conversation about how effective they are for assessing in vivo DDIs.
Thank you. The next question I'll address, this one is addressed to Daryl. Now, herb-drug interactions are often discovered incidentally. How can we anticipate the amplitude effect of an herb-drug interaction? And should we plan healthy volunteer herb-drug interaction studies to better characterize them like we do for DDIs, standard DDIs?
Yeah, this is a very good question. Not easy to address this question. Yes, I think that ideally we should try to quantify the magnitude of herbal drug interaction by doing pharmacokinetic studies in healthy volunteer, as we usually do for other drug interaction. But the major concern related to this approach is that you can do this within a trial, within a study, in very well designed study. But if you go to real life, the major problem is that the herbal supplements are completely different, and their content is extremely variable, and it's very difficult to be predicted. So ideally, the answer is yes, we can start doing this in phase 1 study, but I think that especially for herbal supplement, it is really important to do pharmacovigilance and to reach as much information that we can in our real life, trying to collect information on herbal remedy use. And when there is a herbal drug interaction leading to an adverse event, it is important to collect exact information on the name of the supplement and the content of this supplement.
There's another question for Dr. Arya, and I think again it relates to specificity. I think it comes to rifampicin, which has been shown to induce ALAS1, an enzyme found early in the heme biosynthesis pathway. So the question is CP1, CP3 increased due to OTP1B1 inhibition, or to an increase in the synthesis of CP1, CP3? Is there a way of differentiating these two causes?
Yeah, that's a good question. So there is some literature on the effect of rifampin on those enzymes, and which downstream has an effect on heme biosynthesis. But just the way these trials are designed, most of the trials, if not all of them, are assessing the effect of single dose rifampin on these endogenous biomarkers. And because they're trying to assess the effect of OATP1B1 inhibition, and they're trying to stay away from the induction of rifampin, the effect of rifampin on induction of different enzymes. So I would venture out and say that in this particular case, where we are discussing the effect of rifampin on endogenous biomarkers, the majority of the effect is driven by inhibiting the inhibition of the different biomarkers relative to whether it is affecting the biosynthesis, just because of the nature of how these trials are designed.
And Dr. Arya, just a follow-up question. Do you believe a conversation could be had with regulators based on the current available data for potentially granting a Rosuvastatin DDI study waiver for new drugs that by a small degree exceed the in vitro cutoff for OATP1B, but show no impact of TP1 in a dose-ranging study?
Oh, yeah, definitely. I think the conversation can definitely be had with, and the agency is always open to new approaches as long as they are supported by validated data and robust scientific data. One thing which I did not get into a lot in my presentation because of the time limitation is the application of mechanistic approaches, like, for example, PBPK. And I can see a place where the data on the endogenous biomarkers can be integrated with PBPK analysis. So, for example, if you are early in development and if you have a range of exposures of your inhibitors on a certain biomarker, that can be integrated into a PBPK model, and you can determine something like an in vivo KI, basically, where you're assessing the effect of your drug on that biomarker. And then that validated model can then be combined with a substrate, another substrate model like a pravastatin or a rosuvastatin. And then the effect of your drug can then be assessed on that exogenously administered compound using this in vivo determined KI. So it's a two-step process where you're determining the in vivo KI based on the biomarker data, but then you're using this in vivo determined KI to predict the effect of your inhibitor drug on a statin in case of OATP. So yeah, to answer that question, a conversation can definitely be had, and I think PBPK can be an important part of that conversation, and then further supported by the validated data that you have.
I have a personal question for Dario. Dario, as a clinician, I think the underreport of CAM and Herbal use is a problem in our clinical patients receiving a lot of drugs. Do you think there's a way of improving this report? And I think, for example, what several groups have done in Africa, so trying to involve the traditional healers. I don't know if there's a way of involving herbal sellers, or I don't know. Do you foresee any way?
No, yeah, you raise a very good point. Underreporting is really a big issue. I can report my personal experience in our clinics. The first time that we ask patients, are you using herbal remedies? The answer is always no. So actually what we do, we are in two people in this service, and one do the first question before starting the visit. One is done during the visit when we ask, when we collect information of the co-medications, and again, at the end of the visit, we again, for the third time, ask, are you really sure that you are not using? And in most cases, we get the information at the third time. So it's really crazy. And another big issue is, for instance, for drugs that are used to improve the sexual performance, because they never admit that they are using this drug. So underreporting is really a big issue. So the only thing that I could say that at least in our Italian situation where we cannot involve other specialists, we can just ask and ask again. During every visit, during every mail we receive, please report each of the substances that you use. We try to use also synonym, not say drugs, we use supplement, but it's really a big issue.
Yeah, I was really pleased that you published so many of your case reports, because I think that really helps to increase awareness. And clearly, those also highlight the importance of using TDM to help you know, assess causality. And now, do you do TDM routinely then in your patients?
Yeah, absolutely. In all of the patients that come to our outpatient service, these are patients that by definition are all on polypharmacy. All the patients undergo therapeutic drug monitoring of antiretroviral medications, and if available also for non-antiretroviral medications, because people think that TDM is cannot longer of importance in the management of HIV infected patients. Of course, I'm not convinced of this. I think that in real life practice, you can get a lot of information still doing TDM of the patient, at least those on polypharmacy.
Thank you. Dr. Ari, I also have another question coming back to the role of regulators. And I thought you did one of your final slides was really excellent at highlighting all the current challenges with the use of endogenous biomarkers. And someone had a question about, you know, will the FDA provide a table of acceptable or recognized endogenous substrates? And I just wanted to get your thoughts on, you know, how close we are to something like this, given all the challenges that you mentioned, like the, you know, the variability and the translation into humans with actual, you know, magnitudes and so on. How close do you think we are to something like that?
Yeah, I think we have long ways to go. And the reason being, I'll go back to my last slide, or the second last slide, where I listed all the challenges. Because the pace of development and research into these biomarkers is not consistent across the entire biomarker. So there is more going on in the hepatic side than the renal side, for example. So I think we still have a lot of ways to go, because we first need to correlate how the levels of these biomarkers are changing with respect to how the levels of exogenously administered drugs change if you're giving the same inhibitor. So if you look at the Rosuvastatin example that I presented, although from an AUC standpoint, we have the same 4 to 5-fold change in Rosuvastatin and in the change of the biomarker, the Cmax changes are really different. It's about 13-fold if I'm giving Rosuvastatin exogenously versus about a 5 to 6-fold when I'm just giving the biomarker. So that has to be put in perspective. And then a lot of the research has to also need to be conducted on other biomarkers. We need to have established methods so that we are able to quantify biomarkers. And then going back to the first question about using the probe cocktail approaches, I mean, in my mind, in an ideal world, we should be able to have a combination of these biomarkers, which are sort of this in vivo cocktail, if you will, that you can assess the effect of an inhibitor simultaneously on those biomarkers to get a readout on what further in vivo trials need to be conducted. But I think we still have long ways to go on that.
Dario, we have 3 questions actually in the same one. So would you suggest that when doing adherence counseling with our patients, that if they are taking herbal supplements, we should discuss that this may negatively affect their adherence?
Okay, yes, more than adherence, if you are able to show that taking a given supplement is associated with a dramatic reduction in the absorption of antiretroviral medication, most of the patients are convinced and stop to use this supplement.
So the other 2 questions relates to, is something else clinicians should be aware, or should be discouraging herbal use? And also, if you're aware of any evidence about why patients stop herbal use, or are they more likely to continue use despite the recommendation?
Well,
and sorry, I also have my personal question. Do you think there's a personality trait? So you see it kind of personality using CAMs?
Difficult. Okay, let's start for the previous question. Again, I have to come back to my personal experience. I was shocked the first time that we had a patient in which we showed that the use of a CAM was associated with an impairment, a block in the absorption of the antiretroviral medication. And his comment was, okay, I know that there are several antiretroviral medication. I don't want to stop my CAM. Please change antiretroviral therapy. So this happens at least with 5 to 4 patients. Now patients are very well informed. They know that they are aware that there are a lot of antiretroviral medications. They are really interested in their well-being. So if they feel good with their supplement, now they say, no, I don't want to stop my supplement. Please change it. It's your problem. You are the physician. Please find the best antiretroviral medication that can match with my CAM. It's crazy for me. So probably there are some, well, with experience, you can identify particular patients that are likely to behave in this way. So most of the patients are okay. If you are able to show that there are some problems, they don't want to experience viral load or viral blip, and so they change. But in some cases, patients do not change, and this is crazy.
As a follow-up, I think I was really glad that you offered those suggestions of online resources to check for the drug herbal interactions. Do you find that they are fairly up to date with antiretroviral data in those databases?
Well, I must admit that most of these databases are not very well updated. So it's not easy to check for potential herbal drug interaction, especially with antiretroviral medication. Of course, there is the Liverpool website that is a very important tool. But one of the main issue when you want to check for this potential herbal drug interaction is that it's difficult to identify which are the ingredients of your herbal supplements, because in most of the cases it's a mix. So you can find a list of 1, 2, 3, 4, 5 different ingredients, and it's really difficult because theoretically you have to check each of these ingredients for potential interaction with antiretroviral medication. And in most cases, it's not easy to find this information. So you have to go to your basic pharmacology and try to predict some potential interaction, but it's not easy to be done.
And do you have a sense of what are the most common types of herbals or CAMs that people are taking these days? Is there a pattern?
Well, in my personal experience, most of these supplements are used for gym, to improve their muscle performance and something like that. So it's something related to well-being, to the physical condition, but there is a great heterogeneity.
Okay, so I think it's the end of our Q&A session. Thank you very much to all the speakers for the presentation and the nice discussion. And I think now we have a coffee break, and see you back in 30 minutes.